Hey everybody, we're doing a little bit of a different intro here for PT Outcast this week, and we're trying it out, see if we like it. So my name is Eric Robertson. I'm the host of PT Outcast, and if you've been joining us and listened to us so far, really, really pleased and honored to have your attention and your audience. So thank you. I've been having a lot of fun building this podcast and getting to have really fun conversations with really interesting people. So this week's episode, really kind of cool. Got to talk to Bartkowiak, who is a physical therapist at Duke. And the reason that I wanted to speak with her was that she very steadfastly refuses to identify herself as like an ortho PT or a neuro PT. She's sort of everything, has multiple specialties. And I thought, boy, that's somebody who's really a PT outcast, right? Like not rowing the boat in the same way everybody else does. And so that was really interesting. I met her at the AOMP conference in the fall, and I think we spoke for just a couple minutes, and I was like, oh, you have a different brain. I want to talk to you. And sure enough, it was a really fun conversation. So without further ado, let's get into that conversation with Allie. It was a lot of fun for me. Hopefully it'll be a lot of fun for you. And let me know what you think. Hey everyone, welcome to another episode of PT Outcast. My name is Eric Robertson, and I am really pleased to be joined today by Bartkowiak, which is a lot of letters, and which is interesting because apparently she also has a lot of letters after her name as much as in her name. And that's the reason why we're having her on today, because I met Allie at the AOMP conference in the fall, and it took about 1 minute or less for me to understand that she was not the typical AOMP attendee. And welcome to PT Outcast, Allie.
Thank you so much for having me on, Eric. This is a really cool experience for me.
Yeah, good. Well, I'm really thrilled to have the conversation and to get to know you more. And I think sort of the defining thing that I know you so far as is that you have a diverse background of things. So I could say broadly you're clinical therapist in the Duke system, and you teach a little bit in the manual therapy fellowship, and you're a clinical instructor, but then it keeps going. So maybe we could start here, and then, for the audience, where we're going is that we're going to talk about how we define ourselves in physical therapy, how we learn, how we specialize or don't specialize, and importantly, how maybe gaining multiple specialties can really enhance the texture of not only the care that you provide your patients, but your own professional practice. There's a lot of things packed up in here. So Allie, let's start with that. Why don't you give us a rundown of all the things that you do and a little bit of some of the letters after your name?
Yes. So primarily I am a clinic therapist. I have my NCS. So a good chunk of my caseload is neurologic conditions, and being part of the Duke system, it's sometimes some really, really out there conditions, other times pretty predictable things that you'd expect: strokes, Parkinson's, things like that. I also have my fellowship in orthopedic and manual therapy, as well as the certified orthopedic manual therapy, the therapist that came kind of before that through my program.
Mm-hmm.
And I do utilize that, honestly, with some of the neuro patients, but it's given me some good background education for chronic pain. So I see a lot of chronic pain patients as well. I am a clinical instructor. I have a long-term student actually with me currently in the clinic she wanted a good broad background. She's getting a good broad background. There's another group of students that I'll have coming through in June. I TA for Dr. Cluley's manual therapy elective class that he teaches at Duke. I TA for another class where it's students getting their first real exposure, treating a patient, going from evaluation to planning everything to discharge. It's all volunteers. The patients know what they're in for, but that actually wrapped up this morning, and it's a really great experience. I help out with the cervical, and I believe next year will be the thoracic units as well for Duke's manual therapy fellowship. I have my ATC, and I'm a licensed athletic trainer, so a couple times a year I'll do some outreach at some local high school sporting events. It's usually some of the club soccer we have in the area, or honestly this wrestling tournament I keep going back to every year that is wild time. But honestly, I see through all of this, it has been kind of how you introduced everything really spoke to me, because I never saw it going this way, and I never saw myself turning into, now most recently, a specialist and an expert for people that have Ehlers-Danlos syndrome and other conditions similar to it, which is a big upcoming thing, and they deserve it, but everything's kind of culminated to this, and it is nowhere near where I thought I would be entering college. So I'm loving it, though. It's pretty neat.
Yeah, so I'm curious, when you were entering college, where did you think you were going?
So I went to Ithaca College, and I was in the last cohort where they allowed people to be athletic training undergrad to transition into their PT program. And Ithaca in general has a direct acceptance PT program, so you don't have to take the GRE, you just have to maintain the standards in undergrad. So I really, truly thought I was going to go work professional hockey to some extent when I was a freshman in college. I'm from Buffalo originally, and sports are really serious in that town. So I really anticipated going that route. And just through events, it kind of became obvious that that wasn't really what I was interested in. And it wasn't where my personality would be best utilized for people.
Okay, I like that. The personality would be best utilized.
Yeah, it's a different way to think of it, but we're still people after all, right?
Yeah, no, it's good, and I think after the conference, you and I connected on probably Instagram, and the first thing I noticed was that you were also an outlier in terms of your humor, right? Like the things that you yeah, the things that you post are not like other things, and so I was like, wow, she really is a PT outcast. We have to have her on the show.
Yeah,
So
in this political climate, there's plenty of great jokes to be made,
endless.
Endless.
So also a little small world moment. You mentioned like teaching with Dr. Cluley. So Derek Cluley, we entered our manual therapy fellowship together.
Oh,
And
neat.
yeah, so you might not know that, but we did that, and we like to take the claim that we were the first two people in the evidence in motion fellowship ever. And then we also like to conveniently forget that we were not the first person to graduate. We're racing each other to graduate from it, and somebody else eclipsed us. Yeah, it was really sad. So nobody else probably cares about that, but he and I do. So you can talk to him about that. But we were a little boring. We just did the manual therapy fellowship, so we didn't also have this neuro side. And I can remember being at a lot of conferences, manual therapy conferences in particular, talking about this like very obvious overlap between patients with neurologic deficits and the way that we treat with manual therapy techniques. And I've been in some neuro clinics. I've done some like shadowing and co-treats in neuro clinics. It's really fun. But like, what came first for you? Was it the neuro side or was it the manual therapy side? Like, how did you decide to combine these two things?
That's a pretty goofy story. So I was working in Texas at the time for University of Texas Medical Branch, UTMB, in one of their clinics, and the previous manager was retiring, and she saw a lot of neuro patients, and she just kind of asked would I be interested in taking that caseload on. Then in the years before that, I had already started and been enrolled in the Optum Manual Therapy Fellowship, the one based out of Houston. Fantastic program if anyone's considering it. I really had a great time and great networking, wonderful instructors. So I was already pretty invested in that when she says, I'm stepping down. I really need someone to fill this role. I think you'd be a good fit. That phrase has haunted me my whole career. So I said, okay, yeah, I like a challenge. And I get into it, and I'm realizing I have focused so much in one direction. I did not have enough. I didn't feel confident enough to treat these patients effectively, appropriately. And I was
The neuro patients.
The neuro patients, yes.
Yep.
And I was sitting talking about it in the clinic one day, and one of my coworkers says, well, you could just take the NCS and the studying will get you ready for it, because I know you're not going to just read all of that on your own. You'll need a reason. So he stood next to me and bullied me into registering for my NCS in that moment.
In the moment.
in the moment, in the clinic. And
that's not a small fee. Like, that's a commitment.
No, and my clinic system that I worked for did not reimburse for fees like that. I know some do, but they did not. So it was a big decision, and it ended up being a big stressful event because I sat for the NCS on Friday, March 13th, 2020.
Oh,
Which
wow.
you
That
can
was
think
the day after. The day after.
it was right about when
Yeah.
everything was ending. Yeah, and Houston being a really large
Ending, she said.
city. um, yeah, I was pretty certain I was going to have to reschedule that, but they kept it on, and I did not have to sit and try to retake it. So finishing that, and then it took a little bit longer to get my mentorship hours done for fellowship because you're not going to not finish that. So it was just a bunch of things happening at once.
So
That
this is even more fascinating because there wasn't one before the other. This was happening kind of simultaneously. You were studying and learning this neuro and doing your fellowship.
Yeah, and I wouldn't recommend doing it that way. It was a lot. It was a lot of stuff.
It's a lot of stuff, but I'm sure it also um, uniquely shaped how you formed synapses during that time, right? How you made memories and how you process things clinically. And I'm wondering, did you have any mentors that pulled from one to the other, or were you the person who was doing that integration of like, well, I'm learning this in manual therapy and I'm learning this in neuro, and maybe these things go together, maybe they don't. Like, how did that work as you were trying to integrate that content?
Yeah, so I did have a really good mentor that he is not a neurotherapist, he is a manual therapist, and he was he always kind of pushed me to try to see if there was a parallel because he for his, I'll say limited, but they're not limited, for his limited certifications, he always saw that there could and should probably be something better connecting the two areas, something bigger. So he always pushed me to think about how can we use neuro rehab principles with patients and how can we use manual therapy on neuro patients. And just never forgetting that everybody has a brain and nerves, everybody has muscles and bones. There shouldn't be this much separation in the process. And that he was a bigger influence on my career than I think he realizes. So,
Well, I'm glad that you said that because I was also just going to point out that you're giving this mentor a really important compliment, and it's a good lesson for mentorship everywhere, which is to be an effective mentor, you don't need to know the answers.
yes, I think that is absolutely huge. I think when you're a clinical instructor, you do know a lot of the answers to the questions that they're asking, but when you're past that level, when you're past that new grad, even past that residency level, you do find yourself kind of at a loss for answers sometimes, and not to your detriment, but just kind of to push you forward and keep you like, I don't know. Let me look into that, and who knows, you might find a new favorite subject to study.
Yeah, or in this case, like I think there could be an answer. I'm not going to know. I'm going to ask you and let you bring your expertise into the thing.
Absolutely, yeah. I think that groupthink is
Yeah.
always underutilized, or not always, but very frequently underutilized in our profession. So I think he was really a big advocate for that as well.
So I also see in your list of letters you have like a certification in aging adults and and also now you're working in this Ehlers-Danlos specialty clinic. Like how did you get to that part of this?
So part of neuro rehab, there is going to be a lot of balance and falls patients, and a lot of them are older.
Mm-hmm.
And I have a coworker who she got a little bit of a slower start with her career, but she is just so insanely motivated. I've never seen anybody push harder with doctors and other providers for the best of their patients. I've never seen anybody work that hard. And she noticed, like, we were getting a lot of older patients that were we underdosing? Were we overdosing? Were we not being specific enough? And she had been looking for this course for a while, and that special certification, the Certified Exercise Expert for Aging Adults, has been on the East Coast one other time. And it's through the APTA, so it's a very solid backed, completely research backed everything. But when it was coming to Virginia, she was like, we got to go.
Mm-hmm.
So she like signed me up for it and everything. We went and we had a great little time learning, and it has been really helpful because it looks again at the whole person and how medications impact people and how blood pressure and normal things that everybody deals with in aging, but how to prevent it, how to work with it, how to reverse it, which was a very cool thing to see because I don't think in PT school people learn about it.
Right.
And
Okay. Good point. Yeah. Fair point.
I think we learn about it as like, well, you're older, let's just make sure you're not falling much. But in the course, they used the phrase, strong legs keep you up, strong arms keep you out of the nursing home. And that has stuck with me in such a way.
Yeah. That's like a motion is lotion kind of
Yeah,
mantra.
exactly. It's something that we should all be considering. And as we hit past 30s, 40s, 50s, it becomes a lot harder to gain and maintain muscle mass. So things that we should all be doing now is I learned a lot of that through that course. And then the Ehlers-Danlos part is there's another clinic I help out with that I was told I'd be a good fit for, and
You should watch out for that phrase. Yeah.
it's following me around. And then this one was pretty crazy. I had a patient that had complex regional pain syndrome, and we had gotten through it, and she had huge success with it. She'll never really be a marathon runner again, but she's like, I can walk my dog and hang out with my kids without pain. I'm happy. And she has another condition, and she was seeing a geneticist for it and mentioned me to him and how great I am for her rehab and everything. And then he shoots me an email and says, I hear you like complicated cases. What do you think about Ehlers-Danlos?
Okay.
And I'm like, well, it's an underserved population for sure. A lot of people just don't have a lot of understanding, and they're nuanced, and there's a lot to consider with it. And he goes, okay, I'm going to send you all of my patients.
Fair. Okay.
Which is doctor speak for I think you'd be a good fit for my patient.
You so there's two things, right? I see a pattern here. So we're pulling back and looking at the big picture. One is there seems to be a spontaneity to you gaining like areas of practice. Right. So,
Yeah.
I mean, I'm gonna resist. We could drop you'd be a good fit for this in the podcast, and then suddenly you'd be signed up we could probably talk you into signing up for a different specialty today, maybe. But we won't do that. But the other thing is you're not afraid to go try these things that might not be like what you thought was in your lane. Right. There's an openness and a curiosity maybe to learning.
I have always felt that, or my mom always said, if you're not learning something, what's the point? And, that's a very mom thing to say, but it's been really good because it's keeping me engaged in the world around me. And I could continue to learn things about things I already know and just get more expert in niche in certain things. But I want to know different things sometimes. And it's like when you learn a skill or a hobby, we all have the craft stuff that we keep, and we go back to it every so often. But then about once every 2 years, we buy a whole new craft system, and we're like, okay, this year I'm going to try crocheting, and then you find out you can't use the crochet hooks for whatever reason, so you just put it back in the closet. So I think the way it's actually translated for me, though, is every time I've gone into one of those, well, let's just investigate a little further, by choice or not by choice, it's stuck, and it's been very interesting and rewarding for me. And I think it's really kind of shaped where things are going now, because now I'm trying to work with other providers to get a full multidisciplinary Ehlers-Danlos clinic started. It's very, very ground level right now, nothing crazy happening just yet, but seeing this, again, this is nothing I ever thought I'd want to do.
Yeah, right.
Spearhead a major project, but seeing the need, knowing what I know, let's try it. What's the worst?
Well, good for you. Good for you. And so I think we've gotten through. We're I don't know, maybe 20 minutes now into our podcast, and we've concluded what your roles are. So that's awesome. But so I guess the second part of this conversation where I'd like to take this is, given all that experience, how do we think about how PTs specialize or not specialize? How do we learn? How do we do things like that? And so I want to start that just by asking you a question.
Mm-hmm.
how do you define yourself as a PT? Like, are you a neuro PT? Are you like, what kind of PT do you do? Like, you get that question all the time. You're on the plane, somebody's talking to you. You don't really want
Mhm.
to tell them you're a PT, but then, yeah, what do you specialize in anything? Like, what do you say?
So for if it were a patient or a lay person, if you will, I'd probably say, oh, a little bit of everything. But if it's another therapist, I kind of catch myself saying anything but pelvic and peds because those are just areas I don't have much background in, but I have a ton of respect for them and they deserve all of the attention that they get. So that's usually how I describe it, which isn't a great way to describe it now that like we're having this conversation, but it makes sense to people. But then it usually does turn into like, oh wow, so what does that mean? And then I
Mm-hmm.
go through the list a little bit more. But
I think your teaser
yeah,
to me was something about like, well, I see complex cases, or I see cases other people tend not to.
yes,
Um,
that's also true. I've developed a reputation for just helping people that have a really hard time finding what they need in either the healthcare system or sometimes they're just not responding to normal PT treatments. I say normal, I mean traditional
mhm.
PT treatments, and then having the neuro background with the fellowship background, and then all the knowledge from the aging course about the health and like the body and that sort of thing. All of that can come together for these patients a lot, and that is essentially what an Ehlers-Danlos patient is too. They've all got so many systems involved to shape it up. They're just complex patients consistently.
Yeah, so when I was teaching at Texas State, I taught alongside this wonderful woman, Brenda Boucher, and she was a hand therapist and a manual therapy fellow. And I've never met another one, but I always thought she was like a physical therapist ninja because she was combining these things that often didn't get combined. And I learned so much from her. And so maybe there needs to be like a little like conclave of PT ninjas who are combining different things, and you all could have like receptions at conferences and talk about ninja things. But has your journey, has it influenced people around you? Do you see other people doing the same thing of like combining multiple specialties, or not so much?
Not so much as far as PTs go. I think
Mm-hmm.
the students that experience it and see the benefit that the patients that haven't been helped are getting from someone that's finally seeing them and hearing them, I think students are a lot less pushing themselves towards a specific specialty at that after experiencing that. But I have kind of bled over into one of the OTs that I work with. She sees the efforts and the rewards with these complicated patients, and now she's diversifying her education a little bit too. So a little bit of OT going on, but not the same as PT.
Yeah, so let's talk about this not so much a little bit.
Yeah,
I think about, um, you know, one of the missions of entry level physical therapist education, pretty much every program, is to create, like a generalist or somebody who could then specialize, right? And in so doing, you hit the standard for what is safe practice as a physical therapist. Um,
yeah, I
and,
agree. I would
yeah,
like to agree with that. Yeah.
yeah, and then from there, we're sort of guided, and language and implicit bias. Everybody sort of guides you to like, what's your specialty going to be? Like, what do you want to do a residency in? What? How do you define yourself? What practice area do you see? And so they're usually like one way train paths to an
Yeah,
area.
I agree with that. And I see it often. Duke does it with some students, not with all of their students, but if a student comes in with a very specific area of interest, they just cater to that area of interest. I know there's other schools that do it too. I just see Duke's more readily, so I can really only truly speak to them. But I don't know how I feel about that because you cannot always guarantee that you're going to treat just that specific specialty that you see. And you don't really know what you like until you've tried a little bit of everything.
Mm-hmm.
So I never thought I would do neuro, and I had one clinical that was a little bit of pediatrics, a little bit of neuro, and I didn't really enjoy the pediatrics part of it, but I tried it, and I liked the neuro stuff, didn't hate it, so I never really wrote it out. Oh, here's a cat. I should have warned you. She's we had to do the one class that I TA. We had to go virtual today, so I've been in this spot pretty much all day. There's
Yeah,
Olive. Hi,
that's
Olive.
that's cute. Yeah, the cat was just black. I thought there was something happening to your screen because it was just like a black wave coming up. Yeah. Um, so
House Panther. Sorry about
no worries. Animals are really welcome, especially if you want to reference maybe episode 3. There was really my now late dog Mackie was the
yeah.
hero of episode 3 alongside Mike Pasco. So, I guess when I was developing as a PT, it had probably my second job. I found myself in this clinic owned by this fun gentleman named Elmer Platz. And Elmer went on to later become like the treasurer of APTA. He was really engaged in the profession. He was, I should have Elmer on this. He's maybe the first PT outcast I ever met. He's a little bit of a different fella and has a lot of texture in his life. And as I was working for him, he said to me one time, he's like, yeah, if I was your age, I would go work in like every single setting I could. I would go try out all the different settings in PT.
Absolutely.
And I did. I think he got mad at me because that meant I resigned from my position with him. but but I did. I went and I started doing different things, and I ended up like in acute care. I ended up with pediatrics. I ended up in like adult neuro, like occupational health. So I did all these things, and for me, it added so much important texture to just being a professional, being a PT. It added a lot of interest where otherwise I was struggling with sort of the clinical monotony.
Yeah, I could definitely see that. Seeing the more complicated cases breaks up that monotony for sure, but I think if a student is only exposed to orthopedics, let's say, they're not prepared emotionally for that monotony, and they're not prepared with how to deal with that one complex case. But by seeing those acute care cases, you can kind of see that, the very acute, for lack of a better word, side of an injury is it's handled a little differently. Or if you're seeing chronic pain often, then when you do get that once in a while chronic pain patient, now you can kind of talk with them a little differently. So that's exposing yourself to a lot of different things, isn't just to find out what you enjoy doing, but definitely to enhance your practice. It's like the Batman tool belt. Like the more things you have in the tool belt, the more things you can use, right?
The Batman tool belt.
Yes.
Yeah, certainly. Part of that, like going in different clinics, is I started. I replied one time to a job posting for. It said PT Fort Gordon, and it was in the military. And at the time, I was very ignorant. I didn't know anything about the Army's like enormous and ongoing influence in our profession.
Oh,
And
yeah.
so I suddenly found myself in this like PT nirvana for me at the point. And then I gained all these skills in like pharmacology and differential diagnosis and imaging, because you have the expanded scope in the military. And those things still influence today. I teach a pharmacology course, and I learned that skill by just going into this practice area that I was like previously unfamiliar with, but being willing to go figure it out.
Yeah, and that's a great example of you just luck into learning things sometimes. You can't choose to try things, but other times you just, oh, oops, I found out that I'm really good at this.
Yeah, luck into learning. I like that.
Yeah, I try to keep a pretty positive outlook. It's, it is what it is these days. But if you can try to find the glimmer in the day, you'll probably learn something different. And you just got to appreciate what's around you for what it is, and not try to make something out of something every time that you see it. I don't know if that made any sense at all, but
No, it is. Well, it's approaching with gratitude and openness,
yes.
right?
Yes, definitely.
Yeah, so I also think there's opportunities in the profession to do some cross-pollinating on how you learn, right? So you might go to a conference like a combined sections meeting, which has all these educational tracks by section, but nobody says you have to go to your section. Like, go sit in if you're an ortho person, go sit in a neuro lecture and learn
Just
some
check it
things that
out.
you've never heard about.
Yeah. Or one of my friends she presented, she has a PhD and a DPT. She went to Texas Women's, and they have a really cool program where you get to do both. And she successfully defended last April I believe, but she presented it at CSM this year, but it's about a military population and not something I would have normally gone to check out, but I'm kind of glad that I did because her area of study was, does a history of low back pain have a predictive effect on developing a lower extremity injury in soldiers? And it's, of course, they had almost 500,000 participants because it's the Army and that's how it works, as you know. And they showed a pretty strong correlation that, yeah, there is actually an increased likelihood. And I'm sitting there the whole time like, wow, we could probably directly translate this to the civilian population as well.
Mm-hmm.
And then maybe I should start asking my patients with these weird, kind of nondescript, insidious lower extremity injuries, well, do you have a history of low back pain? Then we could start thinking, is it compensatory versus injurious? So it really got me thinking about, wow, this is bigger than the Army.
Yeah. I mean, and that's, I think, the point of why they do that research, especially with those really big data sets, right? Like, you get some flack because it's not like, prospective research or really like reflecting and looking at correlations, but you're still looking at correlations that are big enough to probably mean something.
Mm-hmm.
So
definitely with that size.
So as you go through, like, and you're interacting with students as a clinical instructor, you see them in maybe in the fellowship, do you try to season them with this idea that you can be more than one specialty? And how do you do it, if so?
I do try to encourage people to have an open mind about diagnoses and not just put somebody in a bucket because they come into you with a label, whether or not it's the label you're seeing them for.
Mm-hmm.
Right. I encourage students specifically to not specialize right out of school. I have nothing against a residency. I think they can be really, really helpful. I did not do one myself, but they're really helpful for people that are definitely committed and will definitely pursue that track. And it gets you there faster and a little stronger of a clinician afterwards sometimes for some people, if they can't always synthesize the data the same way.
Mm-hmm.
But I encourage students to not look for that right away all the time because, kind of like you were saying, like it's just pushing them in a direction and they're not seeing what else is out there. It's, if they're in a fellowship, I'm not going to say, well, maybe you should look into this type of a thing afterwards because that's pretty far along to be saying, let's change your mind.
Yeah.
But like our current fellow in training, he did an ortho residency and he did a separate spine fellowship before he came to this manual and orthopedic fellowship. So he knows where he's going with this. Luckily, he's just got such a lust for learning that if there's anything that I can give him that's a little outside of the box, he's gonna just absorb that like a sponge. Some people that come in like wanting a specific specialty, though, they're a little harder to convince. I've learned.
Right, because they sort of have this preconceived idea of their practice in the future.
Yeah, exactly. And we can't know where we're gonna be in 2 days, let alone 5 years. So I've successfully gotten this far without a 5-year plan.
Yeah. It's always a balance with these things, right? And I like the idea of like adding texture versus having to choose a different direction,
Mm-hmm.
right? So like if you're going on this train track on orthopedics and this train track is leaving the generalist station and it's going, you don't necessarily have to like reverse, go back to the station and start over. What you can do is just lay another track and divide your car and keep going, right? And like the trick is everybody's all still together. And so, I think if there's educational opportunities that gave maybe easier ways for people to diversify content, like bridge type courses versus having to like do a whole residency or a fellowship, like those are commitments. It would be fun for there to be like more courses at combined practice areas. That
would be a really neat thing to help people. Yeah, I completely agree with that. I'm sure go ahead, I'm sorry.
No, yeah. When you're thinking about diagnoses, you mentioned like talking to students about labels and not giving them like one label. Do you find like something like using ICF language, do you find like that more helpful for people to like translate and combine different practice areas?
Most definitely. Yeah. I think because if you look at somebody that's coming in with Parkinson's, like you're picturing something specific in your head. And I've never met two cases of Parkinson's that looked even remotely the same.
Mm-hmm.
But if you look at it from an ICF standpoint, Parkinson's is actually a great example because the way they break down their practice guidelines is, is it a balance issue? Is it a gait issue? Is it an amplitude issue? So you just look at like, okay, impaired balance is their main concern, and is it static or dynamic? And then you address that impairment in an appropriate way. And if you look at low back pain, that's similar to what the treatment-based classifications for low back pain are, is you just look at what are they really lacking and address that and then progress from there. So if you look at it from the ICF and almost even like a diagnostic, like an ICD-10 diagnostic approach,
Mm-hmm.
it might even be easier than if you just look at the diagnosis alone.
Right, right. Get off of the common label and into like what's the diagnosis that changes the way you think or that guides you to treatment, right? Which is the purpose of diagnosis.
The difference between the medical diagnosis and the
Yep.
PT diagnosis. And that is something that I think some schools have gotten a little bit away from
Mm-hmm.
recently, but it's really important now that we have direct access to just bolster why we deserve direct access.
Mm-hmm.
We can diagnose you and we can help you with your exact concerns, which is so different than going to a doctor because your back hurts.
Yeah, right. Like you're getting that's the beauty of PT, right? We solve problems uniquely. So yeah.
Absolutely. We're so on the same page with all this stuff. It's
So how do you think like what should be or is there like should we do something? Should people think about how we can get people to have more broad perspectives, or do you think like someone like you who has a neuro and ortho background, are you always going to be this little like outcast club, like the little PT Ninja club? Is it always going to be a small little group of people doing this, or maybe should more people do this? What do you think?
I really think we should have more of us doing this. I think people are just going to keep getting older, and since medicine is better and people know more about aging, we're going to have more active older adults. We're seeing, I'm going to go back to Ehlers-Danlos. We used to think it was actually like a rare condition, but
Mm-hmm.
that's not what the numbers are supporting anymore. And there are more people undiagnosed than diagnosed, and the number is expanding exponentially every year of the people that are diagnosed. So we're going to see a lot more of this less descript, less bucket type patient as time goes on.
I really like how you're combining sort of this idea of people having cross specialties with sort of like our evolving demographic in this country, right? You're giving like a sort of a epidemiologic reason why we might need to be better prepared to meet society's needs as a profession, cross specialize or I don't know, differently specialize? I don't even know what the right word is.
I kind of like cross specialize. I think there's no better way to describe it than that. But yeah, I think there needs to be more people doing multiple things. And PT school is a good base level, and it's a great way to be a generalist. But you do need to go a little further to really help people get better faster. And older adults are staying healthier longer, and the baby boomers are moving through, but they're not going to be leaving us as soon as other generations were. And Ehlers-Danlos is so much more prevalent than we thought it was, and we're not going to be just seeing these patients that fit neatly into buckets anymore. We're going to see a lot more of these people that blur the lines and reside in the gray areas, and it would not be a great service to them if we weren't prepared for that. And knowing more than just the basics is a great way to prepare for that, and not pigeonholing yourself is another thing that would really be helpful for that.
Yeah, I think about just even how PT school is organized. Like, I'm going to go to neuro class now. I'm going to go to ortho class now. Like,
Mm-hmm.
not every program is like that, but a lot of them are. And I also have to just acknowledge that as you're speaking, there's probably a bunch of like people listening to this podcast who have like geriatric specialties, like jumping up and down, being like, "We've always been here." But I think it's that deep level, like pulling the super manual therapy expertise, the super neuro expertise, like really like redefining what your specialization means. So yes, people with geriatric specialties who have always understood that aging is a combination event. We
Yeah,
see you, and thank you.
definitely.
So.
Thank you. I they've been on to it for a while. They just unfortunately don't get the same kind of publicity that orthopedic specialists get.
Right.
Yeah. But yeah, I think I know that Duke has a complex patient management course too. I have never been like exposed to what that information is or how they teach it, but I think instead of making that again like a neuro class or an ortho class and a specialty type thing, just making it a little more broad and making it more of a patient management and incorporating more complex things as not a fearful thing or not a strange thing, but just something you're going to encounter, that may open some minds up to some things too.
Yeah. As you're thinking about this, this multidisciplinary Ehlers-Danlos clinic that you're creating, and are you going to think about how do you train PTs that you work with to pull in the perspective that you have?
I have thought a little bit about that part. There's so many thoughts in my head about it that I really need to just write them all down. But I thought a little bit about that because they can't be another version of me. That's not a thing that can exist. And when you have a student, you never want them to be exactly like you when they're done, right? And I don't ever want to get in the way of the nuances of someone's practice. But I think there will have to be some level of not just Ehlers-Danlos education, but general medical education to cover some of the other things. Or they do talk about manual therapy management for it, but then that's it. That's as much as they'll say about it.
Right.
So knowing what does that mean and how can I do that, that's going to have to be like on that therapist to want to learn, to be able to help them.
Yeah, well, as we're in the age of clinical practice guidelines, I feel like there's one sitting there waiting for you. So, yeah, maybe that's the thing I'm going to talk you into today. You're going to make a clinical guideline.
There's some pretty powerful physical therapists pushing for the Ehlers-Danlos stuff. So, it would be their fight to lose, honestly. If I went up against them, they got it pretty locked in right now. Yeah.
Good. All right. So, I guess, I really appreciate the whole perspective that this conversation has taken, right? Like, so we started with like, oh, well, I found these opportunities. I wasn't afraid. I approached like this with this open curiosity. And then I got this texture, right? And then that texture helps me think about bigger pictures about the profession and identity and learning. And, I love it. Like you, when I first met you at this conference, you were really, it stimulated my brain about like, whoa, this is awesome. Let's highlight somebody who's combining specialties, and through this conversation too, you're still sort of stimulating my brain about like, what new things could we think about? So, you have some magic sauce about doing things differently, which is really great.
Yeah, I appreciate hearing that. It's the daily for me, so sometimes it takes hearing it from somebody else to like recognize that no, this is pretty cool.
Yeah, it is cool. Yeah, congratulations. And I feel like your students will be pretty lucky to have you. So so good for them. Yeah.
No complaints so far.
Good. Well, maybe you have the personality suited for it. So all right. Well, good. Thank you. I think we're at a good spot here to wrap up the episode before we like drone on and people are like, will this ever end? But no, this has been
several episodes, I think, about various related topics.
I think so. Yeah. We'll have to, there's going to be a repeat. So stay tuned.
Wonderful.
Yeah. And thanks so much for being on the podcast. And everybody, thanks for listening. This was another great episode of PT Outcast.